Thank you, Oli. First of all, thank you for the invitation to this interesting meeting. It's a pleasure to be here to make a revision of amblyopia management. This is the index I want to follow. First, it's important to give some concepts and some background about the current neurophysiological basis of amblyopia. And afterwards, we will make a revision of the treatment of amblyopia from the concept of occlusion to the visual training based on the optic therapy. But also we will talk about new options that are under research now as virtual reality and direct transcranial stimulation. And finally, we will give some conclusions. All of you know that amblyopia is a reduction in best corrected visual acuity without theoretically associated organic cause. But it's true that there are some abnormalities in the way of processing the images in the brain. This is the consequence of an abnormal binocular experience, as you know, due to the mismatch between the images perceived by each eye. The prevalence is very variable depending on the country, on the area evaluated. And as all of you know, since many, many years ago, everybody told us that the gold standard treatment was patching. But since 2015, there are new knowledge on the neural mechanisms of amblyopia, leading us to the development of new treatment options. All of we know now that the visual impairment of amblyopia is partially explained by the reduced complement of cortical cells excited by amblyopia projections. There is no reduction of cortical magnification as thought before, and the visual processing problem is not necessarily located in V1. The problem can lie also in V2 or even in V3. And there is a disorganized amblyopic projections reaching the cortical area. This has a clinical expression, which is the development of interocular suppression that has some specific spatiotemporal properties, and it's known that the common mechanisms of this type of suppression is normally happening as a consequence of abnormalities in the neural activity in the first stage of the optic pathway in the striate cortex, with additional extrastriated contributions that are very differential in the dorsal and ventral currents. It's also known that this interocular suppression is stronger in strabismic amblyopia and that it's correlated with the visual acuity deficit that the patient is relating. There are a lot of literature demonstrating all these issues, and this is something that cannot be doubt because it's clearly defined and explained. From the clinical point of view, the patient experiences some abnormalities, visual perceptual abnormalities, as the presence of masking and crowding that are two typical signs associated to this condition, to amblyopia. Masking is the perception of a stimulus, which is called target, that it's affected by the presence of another, which is called the mask. In this case, the good image obtained from the dominant eye is, we can say, biased or interfered by the bad image coming from the amblyopic eye. Regarding the crowding, is the difficulty in recognizing objects far from the fovea due to the presence of other peripheral objects that are called flankers. This, in the clinical setting, is very clear, this phenomenon when the patient tries to read a line of optotypes and the patient can see the optotypes that are located on the streams of the line, but not those that are located on the sand. But the question is that it's only a problem affecting only this visual processing, not necessarily, because this visual processing is related to other, we can say, lifetime activities. And for this reason, there are several studies demonstrating that the problems of neural activity that are occurring in amblyopia is affecting another areas. For example, it is demonstrated that in anisometropic amblyopia, there is alterations in the spontaneous brain activity in areas like as the left superior temporal gyrus or the parietal lobe. In the case of evaluating with, there is one technique of magnetic resonance that allow us to know how is the tract of the nerves in the blood channels in our brain, which is called the technique of evaluating the fractional anisotropy. It has been demonstrated that in anisometropic amblyopia, there is a significant decrease in fractional anisotropy in areas like the right optic radiation or the fronto-occipital fascicle or the superior longitudinal fascicle. And these decreases in fractional anisotropy are correlated with the level of visual acuity. Therefore, it's clear that this is affecting everything, not only the vision if it's not treated. And in the case of strabismic amblyopia, there is something which is very interesting, is that it's quietly related to alterations in intraparietal sulcus, frontal eye fields, and motion sensitive area. For this reason, it's normal that the frontal eye fields are affected, because you know that this area of our brain is in charge of the conjugated movements of the eye, especially when we make convergence, which is one of the problems. But there are also other areas that's the motion sensitive area that can lead to some problems of perceptual motor coordination or problems of visual attention or making some activities oriented by vision. Okay. For this reason, there are several articles that have demonstrated how amblyopia can affect reading due to the fixation instability and increase of saccades associated to this type, to anisometropic amblyopia, how it affects the quality of vision, not only in children, but also in adults, and also how even can affect accommodation with an asymmetrical accommodative response in this type of patients. For this reason, treatment is crucial in this condition. And as you know, now all the information that I have made a summary because we have a very short time, but as you know that amblyopia, it's something more complicated than it seems. You will see how the treatments have evolved since a main only monocular, we can say, management to the current binocular treatment, considering other aspects, not only the monocular activation of the eye. This was the initial point, the occlusion of patching. As you will see, this amblyopia therapy was very used several years ago. It was considered as the gold standard. There are many research articles showing that it allows the improvement of visual acuity, but there are other problems associated to this type of treatment that cannot be forgotten. First of all, it's very well known that there are some recurrences of the treatment, and this is done because the binocular problem is not solved with only the occlusion of the patient. As all of you know, there is a poor compliance. Not all patients are wearing the patch the time that it's prescribed. And also there is a problem with periods of the treatment periods that are very long and has a very social impact, has a very important social impact in the patient, because it's complicated that the child can wear all the time this eye occluded. Okay, the types of occlusions, all of you, I don't know if some of you know, but in several years ago, it was very typical, the use of full-time occlusion. Fortunately, I think now it's not prescribed, but there are people that prescribe in the past occlusion the entire time of the patient is awake, which is something very hard for the child. Now it's used, the part-time occlusion is normally between 1 and 6 hours per day. And you know what is the PEDIG, which is the Pediatric Eye Disease Investigator Group, which is one of the most important groups in the world developing research on amblyopia, and has conducted several clinical trials, multi-center clinical trials, supporting the use of patching with a very, very huge number of patients. They finally obtain a rule, a general rule, is that occlusion in children from 3 to 7 years old can be done depending on the degree of severity of amblyopia. If it is a moderate amblyopia, we use occlusion 2 hours per day. If it's a severe amblyopia, occlusion of 3 hours per day. But it's true that they demonstrated that more than 6 hours is not effective to obtain more improvement in patients which are patching resistance, we can say. In case of no improvement, with 2 hours per day, they recommended increase to 6 hours per day. There was also evidence of improvement in children of 7 to 12 years old, or even to 13 from 17 years old. But the problem is that this is not possible currently, because this type of children cannot wear a patching going to the school or to the high school with the eye occluded. This has no sense. For this reason, during the last years, the combination with vision therapy was proposed as an option to accelerate the recovery and minimize the treatment period and the number of hours that the patient is wearing the occlusion. For this reason, this was the next step, combining vision therapy with occlusion. There are many evidences. For example, in this retrospective study from Fitzgerald and Krumholz in 2002, they revised the clinical histories of patients treated with anisometropic amblyopia in their clinic, and they assess how was the evolution of the cases at 1 to 2 years after finishing the treatment. And they observed that only 50% of patients maintained the result if they were only optically corrected, only with the spectacles. There are 60% of patients that maintain the results if they combine optical correction and occlusion, and it was very curious that all patients maintain the result when treated with spectacle, occlusion, and the combination with vision therapy. For this reason, there are some recommendations that have been given by some studies of the American Academy of Pediatric Ophthalmology, such as the combination of 2 hours of patching per day with what they call near vision activities. That can be also considered in some way as a way of doing vision therapy, because sometimes they are making exercises that we recommend during vision therapy exercises. And they found that in only 4 weeks of treatment, only with making this recommendation, there was 1 line of difference between patients treated only with patch or only of combining patch with near vision activities. This is one article that was published recently in the pediatric journal Children. We report 2 years of follow-up of the combination of active vision therapy and occlusion in children with strabismic anisometropic amblyopia. And we found that in the case of anisometropic amblyopia, all patients maintained during these 2 years of follow-up the result of visual acuity obtained. In this case, probably only with vision therapy could be enough, but this is a retrospective study of cases that we treated several years ago. And you can see that all patients at least achieve some level of stereopsis according to the binocular function score. when we do that with strabismic amblyopia, it is curious that we also observe, it's important to say that in all cases we achieve bifoveal fixation by making surgery, prismatic correction, whatever. This is important to remark. And as you can see, that most of patients achieve some level of stereopsis, and only a minimal percentage of patients, all of them ex-esotropias, had maintained the suppression, but there was no reduction of visual acuity. Therefore, the more analyzed and greater consistency option is the combination of occlusion 2 hours plus active vision therapy. What happens when the vision therapy or visual training improves with the introduction of the concept of perceptual learning? Let's go. Perceptual learning, it's not something only used in amblyopia. It's also used in many areas, especially in education. It is a process that involves learning better perceptual skills by combining different sensory modalities. For example, if I want to improve your perception of vision, I can train you using a video game, trying that you have a funny time. In this case, with this type of activities, we generate important forms of complex cognitive process. We achieve important changes in the neural circuitry, and we obtain a result which is preserved for a lifetime. And this is very important. There are different types of stimuli that have been used in the past for making visual training in amblyopia with perceptual learning, since the use of the Snellen or a simple optotype to the use of Gabor networks, which is these stripes that you can see that has a blurred, we can see edges, the use of stereograms, or even the use of Bernian visual acuity stimuli. Okay, as you can see, you can combine even in some cases this type of stimuli to improve or to optimize the level of visual acuity that can be achieved during the training procedure. But it's important that you know that it's very important to begin with low spatial frequencies, with more time to give him more time to the patient to give the answer, and using a chromatic stimuli, it can be. And normally what we use is as a visual task, the discrimination of the orientation of different of all these type of stimuli that we have shown before. Okay, it's important when using sinusoidal gratings with Gabor filters as these important stimuli that you know that they have some, although it's not fully understood, because this is something which is under research now, but it's very interesting that when you combine several Gabor gratings in a horizontal line, the phenomenon of crowding disappear. This is what is called lateral facilitation. There are two neural theories about why this phenomenon happens. And for this reason, there are so many visual training procedures that make this type of combination using Gabor patches embedded in a line. But only works if you do it in horizontal line. If you do it in an oblique position, it does not work. This is something that is under research. I don't want to enter in this complicated issue, but it's important that you have in mind that we are investigating more and more about how is the answer to different stimuli of our brain to improve the response of the cortical area. This is something that we are investigating. The problem of all these initial procedures is they are based still in monocular stimulation. Initially, as in this article that we published some time ago, we investigated the use of perceptual learning under monocular conditions. As you can see, that there was an improvement, but improvement was not as the same level that we can achieve if we also eliminated the binocular problem. But this was the first step until reaching dichoptic therapy. And it's important to say that the perceptual learning, one important step that suppose is it was the first time we demonstrated that we could stimulate adults. We can recover the visual acuity from adults. There are several articles published in important journals of neurology, as this published in Restorative Neurology and Neuroscience. As you can see, other important articles like this concluding that patients can improve being adults with visual training. What we have learned from scientific literature on monocular perceptual learning, that perceptual learning allows an improvement of the visual acuity and contrast sensitivity of amblyoptic eyes, approximately a mean of 3 logmar lines, doing 5 to 6 sessions per week of 15 to 30 minutes. It's greater and faster the visual improvement combining 2 hours of patching per day plus perceptual learning, and it's true that the efficacy is greater in anisometropic amblyopia, but the improvement of stereopsis is very limited. And this is the problem because we are not stimulating binocular vision. And the visual acuity and contrast sensitivity of the adult amblyoptic eye was demonstrated that could be rehabilitated. Let's go to the next level, the dichoptic therapy, which is what binocs do. As you know, dichoptic training is a tool for amblyopia treatment using separate but simultaneous stimulation of both eyes. You can modify the contrast or image quality of the image of the dominant eye or the size to achieve a balance with the amblyoptic eye. Once the patient is improving the capabilities, we change this type of balance. Binocular vision is trained through video games or exercises in which you only can make the complete task if you work binocularly, as happened with the games Supercar, Superman, Super Dragon that you can use with binocs. Perfect. There are many studies demonstrating the validity of this type of treatments. There is scientific evidence supporting this option of treatment. It's incredible that there are people still doubting about the potential of this type of therapies. Even, as you can see here, perceptual learning with combination of dichoptic therapy was also demonstrated that could be a very good option for rehabilitating the visual acuity in adults with anisometropic amblyopia. This is one of the first articles published by Chen. What is the problem? Why there is this controversy sometimes with we can say with dichoptic therapy? You can see here 2 articles that they were the only articles, stating that dichoptic therapy was not useful. And it gives a lot of noise, we can say, and a lot of people making doubt about the potential of this therapy. The first article was published in 2018, is a clinical trial, and the first error is that they combine older children with adults. Suppose that was controlled and randomized, and they compared dichoptic binocular therapy versus a placebo video game. They used the dichoptic Tetris on iPod. They use the Tetris, but this type of game is not using a specific stimuli for amblyopia recovery. And they use 1 hour per day during 6 weeks, and they found no differences between the two groups of treated. But you can see that the compliance was 64% in the dioptic compliance group, whereas in the other group was 80%. Therefore, they are comparing two types of groups that were not comparable because they were not used the same number of hours. And in addition, they are combining, it's another point I haven't said, it's important, they combine a mix, an isometropic and strabismic amblyopia, everything combined. The same happens with the first article of the epidemic about the binocularity RAS game, concluding that there were no differences when using compared with the spectacles. But you can see that the first, you can see here, for the binocular groups, adherence data from the iPad indicated that slightly more than half of the participants completed. As you can see, only 50, a little bit more of 50% of patients make the treatment. There was a very important problem with the treatment. Probably another thing that we have to think about is how to improve the compliance with the treatment. It has to be funny, and it has to engage the patient to go on and to make the exercises. This is an article I have the pleasure to share with Oli. It's the evaluation, the first evaluation that was published on the efficacy of Binocs in the group of an anisometropic amblyopia. And we found, as you can see here, that the improvement in visual acuity was very significant in the anisometropic group, but also in the isometropic group, with a very significant improvement of stereopsis, as could be explained according to what we have said before. We are stimulating binocular vision. What we have learned from the scientific literature that dioptic therapy combined with perceptual learning allows the improvement of visual acuity and contact sensitivity, but there is some variability between studies. It's important to say that probably we are using very heterogeneous samples. They have, in some cases, they say that they are combined with perceptual learning, but sometimes they are not perceptual learning because there is no combination of different sensory modes. As happened with the other options, there is more efficacy with anisometropic amblyopia. And now we have demonstrated that there is an improvement in stereopsis also. And also adults can be treated with this option of treatment. But what is the future? Is to finish this talk. One of the options of future that we are discussing is the use of virtual reality. It's true that there are some changes promoted by virtual reality. There is, it induces a cortical reorganization. There is a promotion of activation of different neural connection for different ages, and can make some improvements in motor and functional skills. And until now, the scientific evidence is still limited, especially in children. There are promising results. It seems that it has a very great impact on stereopsis, but it's important to say something. There is still a limitation in the hardware. The head-mounted displays are not designed to be used by children. It's not only a question of height. It's true that it's very heavy, but it's not only this. Interpupillary distance is not considered by some of these softwares, and therefore, if you put a patient, a child with a very small interpupillary distance, you are inducing a prismatic effect that can even generate more problems than improving the result. This is important. There are some previous experience I have worked on as this study in which we observe a very relevant improvement in stereopsis. As you can see here, only in the pre-therapy session, we have 47 patients without stereopsis and almost 12 after eight weeks of treatment. And even, this is one case report that we published, we have the opportunity of evaluating the response of the brain using functional magnetic resonance in a patient trained with virtual reality. As you can see, there is an evolution to a non-effort neural pattern. Initially, there is an activation of the brain, very significant activation of different brain areas, because you need a lot of effort to see, in this case, a 3D or 2D image. But after the training, you can see that there is a very, very very significantly lower increase in neural activity. You need less energy to do the same activity. And this is a new article that we have just published about a new platform of immersive virtual reality in 4 children with anisometropic amblyopia. As you can see, there was also improvement in contact sensitivity, visual acuity, and stereopsis, but we can only treat 4 patients because the head-mounted display has not interpupillary distance for the rest of children. They were extremely larger than we can use. Regarding the last point, is direct transcranial stimulation. It's true that is a promising result. Until now, there are the most important articles are 2 articles, all of them done in adults, showing that there is a very significant increase of visual acuity and using the electrodes in the cortical area. But the problem is that it's very fast, the increase in visual acuity, but also it's very fast, the slowdown of this visual acuity. For this reason, is combined with psychoptic stimulation. And it's true that combining direct transcranial stimulation with psychoptic therapy, the results have been shown to be very, very incredible, but only in adults. We need in the future to make more research on this area and to see exactly the side effects, because there are some side effects as some level of anxiety in the patient, motor problems, and other things that they have to control still. As a conclusion, it's important that in all patients, first, you refract well of the patients, assess whether a loss of visual acuity it can be recovered with glasses, wait 1.5 to 2 months to assess the changes with the glasses, rule out the existence of organic amblyopia. Not all the amblyopias are functional. It's very important, the ophthalmologist, optometrist, multidisciplinary team work. I think it's very, very important to make this team. You have to escape from experimenting with therapies without scientific basis, because we are talking about the vision of a child. It's very important. And combine the options that are necessary. We have seen that the combination of perceptual learning with dioptic therapy is an excellent option. And only the last recommendation, if you use an amblyopia training software, please first check that is scientifically validated, that can be used on the intended device. You have to see the screen calibration, the tablet resolution, that this system use truly useful stimuli that can combine or not with patching, and try to avoid of commercial or miraculous messages that are not reflecting the reality. This is everything I want to say. Thank you very much for your attention. This is my mail. If you have any question, if I can help you, I'm now open to any questions that you can have. I am pleased of helping you.